Good morning. Is this working? Can you hear me? Hello, is this working? Can you hear me? It is working, but it's not very loud, is it? So this is a warning to our speakers to stand really close to the mic, like almost lips touching, because if you stand here, you won't hear it as well. So that's interesting. Are we good to go, Dave? Dave McCollum? Are we live? Should I not be saying bugger or shit? I'm just waiting on the thumbs up from Dave there. Dave McCollum, DC Media in the house. Keep your eyes open over the month that follows the walk for David's production, DC Media's production of the next 2 days. It's always fabulous. He's very, very cheap, but but he's also, more importantly, very, very talented, and he's a man in long-term recovery. If you want to support his business, we would really appreciate that. So, good morning, everybody. Thank you for coming. My name is Anne-Marie Ward. I'm the CEO of Faces and Voices of Recovery UK. That is the culprits involved in putting on the UK Recovery Walk every year, for which, if I haven't already given you short shift this morning, I will complain about endlessly, because every year from scratch we have to raise funds to do that, which is an absolute tragedy. Now that even we're in our 16th year, we've still not been able to get sustainable funding for that, and it pains me that we still have to have a begging bowl every single year to do it. But anyway, there we go. This year in London, it has been fantastic in terms of support from the strategic bodies and operational services. They have rallied round to help us like never before, financially as well. They've been hugely supportive in a way that we've never experienced, but unfortunately we can't take any of that money forward. We've got to spend it all in London, so come to the event tomorrow and I'm sure you're going to have an amazing day. As some of you know, we're in Crystal Palace Park from 12 until 6. It's going to be a huge festival and celebration of recovery, and we try to do our best to acknowledge and celebrate all the different paths to recovery, and tomorrow you'll be able to get wee tasters of some of those paths. If you're fed up with the one that you're on just now, you might want to change over, or if you're working in a service, you might want to explore some of your prejudices against other paths and come and sit in and listen to some of the experiences that are on offer. So today, as we always do at our conference every year, we platform all the best people in the area, in the region that the walk is held. And as I was saying earlier, we also hope over time to have those platforms reciprocated. We are very much a relationship-based organisation, and we want those relationships to be based on honesty and respect. And obviously the theme of today's conference is
loud. Stigma and disrespect for people in active addiction, and how that can prevent them stepping up and asking for help when they need it. After the break, we're going to move into looking at self-respect and taking care of yourself in early recovery, focus on well-being. And then after lunch, we're going to kind of flip it over a little bit and look at respecting others. So in long-term recovery, the whole idea of being active, productive, fruitful citizens and being of service to others and earning respect in the same way that normal people do. So our first speaker, Dr. Aswin Dhanda, he's a consultant in hepatology. That means he works day in, day out with people with alcoholic liver disease, and he's also a professor and academic. So it's a proper conference. We've got several academics today. When we settled on the theme of the conference, somebody sent me a link to a piece that Dr. Aswin had published online, and it was his observations that people were presenting too late for treatment because of stigma around alcoholism. It was a fascinating read. So immediately when I'd finished reading the piece, I searched for his email address and asked him would he come and open the conference for us today. So, Dr. Aswin, over to you.
Well, good morning, everyone, and thanks, Tony, for the invitation to speak today. And it's a real pleasure to be here, and I'm really looking forward to hearing other perspectives of recovery and addiction. So, as Tony said, I'm an academic and I'm a liver specialist. Let's see if the clicker works. Oops, too far. So I'm a liver specialist, and most of my practice is around dealing with the health consequences of alcohol use disorder, so advanced liver disease and addiction. So today I'm going to talk to you about stigma, and I'm going to show you that it really underlines and is the driving force for liver disease that I end up seeing. I'm going to tell you what stigma is. I'm going to tell you why it's important in alcohol use disorder. So I'm going to be using these acronyms, so just bear that in mind. AUD, alcohol use disorder, and ARLD is alcohol-related liver disease. And then what can we do about it? And I'm going to briefly talk to you about a project that I'm leading called Arms Hub, which is the first step in trying to help us deal with some aspects of stigma. So I'm going to start with a clinical vignette. So this is a real patient that I have been looking after over the last few years. So her name has changed, but otherwise it's real. So you can see the details there. Jo attended multiple times to hospital with various problems relating to alcohol use. She was turned around from the accident and emergency department on several occasions and had short periods of abstinence from alcohol, usually only a few weeks. Unfortunately, have I gone too far? Sorry. Yeah. So the background is that she is a victim of domestic abuse. She is a young female, 36 years old. She didn't have any children, but she wasn't working, and she had been drinking heavily for at least 5 years. And commonly, I've been hearing the story that during the pandemic and lockdown, there's been increase in alcohol use, and this was the case for Jo, who had really escalated her alcohol use. So she was drinking 3 bottles of wine a day and presented to the emergency department really in extremis, with signs of liver disease. So she had jaundice, so yellowing of the skin, and her abdomen, her tummy had all swollen up. So we fixed that acute problem, detoxed her from alcohol, turned her around and got her home. And then she was back and forth over the next few years with a few attendances. And during that time, her liver disease was getting worse and worse. She developed some of the complications of cirrhosis, which is scarring of the liver, which are known as ascites, that's fluid accumulation in the tummy, and jaundice. So those are signs of liver failure. So really showing that things were getting worse. And sadly, she wasn't well supported by our service because we just don't have the resources for that, and she wasn't able to attend our clinic. And so she never came back for follow-up, very rarely. Then earlier this year, she came in with a really severe complication of liver disease, of end-stage liver disease, of organ failure. And she had a very large gastrointestinal bleed from varices, which you may well have heard of, a complication of cirrhosis. And sadly, that was catastrophic, and she ended up with multi-organ failure and subsequently passed away in the intensive care unit. But this is a story that highlights many issues that stigma drives. She first of all presented very late, and that's what Tony mentioned at the beginning. One of the issues that I feel is a challenge is that we don't identify people with alcohol use disorder until it's way too late. So she was ashamed to see her GP, to seek support. She felt that it was her fault and she was the one that had to do something about it. Once she had come into hospital, she was very grateful for the treatment that we gave her, but she felt she didn't want to waste our time. There were better people that could be supported with our precious resources. So she didn't want to come back to clinic for that reason. Well, that's one of the reasons. And then she was hiding alcohol use from her family and friends. So it was not apparent that things were getting worse until it was too late. And finally, she was very isolated. She hid away from her family and friends and didn't have a support network. So these are all issues that are driven by underlying stigma. So I'm going to tell you a little bit more about stigma and what it is. This is the dictionary definition of stigma. So it comes from many years ago. In the 16th century, it was a mark of punishment, of branding, to differentiate someone who was different, who had done something wrong. And so now we use it as a mark of disgrace, so showing that person is separated from the rest of society. That's what stigma means. So how does that apply to patients with liver disease? This is results of a survey of about 150 patients with all sorts of liver disease, not just alcohol-related. And I know the print is quite small, but you can see that there was several questions asked, and the people with liver disease were asked to say whether yes or no they agreed with these statements. And a vast majority of them agreed with many of these statements around stereotypes, discrimination, shame, and social isolation. So if you look at a couple of them, The top one is people they feel ashamed because people label them as being an alcoholic. And they feel that they're bad people because they've got alcohol problems or liver disease. So this highlights there are different types of stigma. So there's the stigma that is driven by that person themselves. There's stigma from the general public about discrimination and the way they make people with liver disease feel. And then there is stigma around the way services and support is structured. So the stigma that comes from the public drives feelings of discrimination and stereotyping, whereas there is also the self-stigma that I mentioned that really compounds the issues that the person is feeling and drives that shame, which was highlighted by the case of Joe that I explained earlier on. So what about stigma in a healthcare setting? There are several types of stigma that we deal with that I see on a daily basis that maybe you don't think about necessarily. There's structural stigma, and that's to do with the way policies are set up, the way services are commissioned, access into services or treatment that might discriminate against certain groups of people or not allow access to the people that might need that support. That's a form of structural stigma. There might be government policies that are also stigmatizing in that way. And then secondly, there's healthcare professional stigma. So that stigma that comes from doctors, from nurses, from other healthcare professionals, and it's around the way we as healthcare professionals treat people with addiction or liver disease or alcohol use disorder, and it's driven by the way we speak, the language we use, our professional attitudes and behaviours, and that really does drive stigma, and it sort of feeds into the person's self-stigma. I've got a couple of examples of structural stigma just to explain that in a little bit more detail. So one example that is a real problem in people that I treat is that so they have alcohol use disorder, they also have liver disease, they also often have significant depression, post-traumatic stress disorder, other mental health disorders. But one of the challenges in certain services around mental health or addiction services is that they will not see people who are actively consuming alcohol or using substances to treat their mental health problems. So that is a form of structural stigma in which they've placed barriers to the people that really are in most need of accessing that treatment. So that's one example. A second one is that there's a particular condition that I deal with called alcohol-related hepatitis. That's a very severe condition in which the liver starts to fail, and once someone has this, they have about a 1 in 3 chance of dying within the next 3 months. So it's really serious, and we don't have any good treatments for it. But the way that services are structured in this country is that one of the only real life-saving therapy, which is liver transplantation, is not permitted in people who have been recently drinking alcohol. So that's to do with healthcare policy, and that's driven by public's perception and stereotyping of people that have alcohol use disorder. And then the final example is about integrated care. So I mentioned that people have alcohol use disorder, but also have other mental health conditions. They have liver disease, but all these services are commissioned separately. They work in silos. There's no communication between them, and that causes barriers to accessing treatment. So these are just a few examples of the structural stigma that we don't normally recognise. We just accept that this is part of what the health service is like. But that these are things that we need to address and deal with to tackle the underlying causes of stigma. I wanted just to describe stigma in healthcare professionals. I was talking to someone earlier on and explaining that my colleague sitting next to me in my office, who is a liver specialist as well, has very different opinions and beliefs around people who've got alcohol use disorder and alcohol-related liver disease, and some of the words that she uses can be quite offensive, and it's disappointing that even in a specialist that deals with this condition, there is stigma. And it comes from all levels of the healthcare service, from the GP reception to the paramedic, to the emergency doctor, to the nurse on the ward, to the liver specialists. And it's something that we need to address, be aware of, address it and deal with it. And it comes from a lack of knowledge. So is there misinformation, ignorance around what the true driving forces are for people with addictions? And do they have negative attitudes to this group of people? So is there that natural discrimination that healthcare professionals have that needs to be dealt with? And then what are their behaviours like? So are they exclusionary? Are they separating people out that have addiction problems? Are they treating them differently? Is the behaviour different around them? There's some studies that have shown that people with more negative attitudes have what's called microaggressions, so they have minor behaviour changes that are only apparent when they're dealing with those particular types of people. So those are different aspects of stigma that I've told you about. And why does it matter? Because it drives self-stigma in the person that is affected. They start to believe that they deserve to be stigmatised. As you heard from the experience of Joe, they deny their alcohol consumption both to their family and to healthcare providers. They experience dehumanisation, they disengage from healthcare, and the studies have shown that they are 6 times more likely to avoid healthcare. And what happens in people with liver disease, they end up getting more and more liver damage. So they get progressive disease from alcohol use disorder and liver disease, and they end up like my patient Joe. This is just a short overview diagram of the different types of stigma and what the actual effects are. And we can see that the different stigma types I've explained to you all sort of converge on that experience of self-stigma, and that's what leads to hiding alcohol use, isolation, avoiding care. It actually drives the vicious circle of alcohol use and then results in that burden of increasing alcohol-related liver disease or alcohol-related harms. So just to conclude the first part of the talk, I hope I've explained to you there's a few different types of stigma. They all really converge on self-stigma, and that is what's underlying liver disease and alcohol-related liver disease. And it leads to worse health outcomes. So I'm just going to briefly tell you a little bit about some statistics around alcohol use and liver disease and why stigma is really important in this condition. So this is the global use of alcohol in terms of total pure alcohol consumed by each individual on average per year and it is on average globally, it's 6.5 litres of pure alcohol per person per year. And when you think that large parts of the world don't drink much at all, the people that are drinking, it means they're drinking a whole load. And there's more alcohol use in the northern hemisphere, in Europe, Russia, and less so in the southern hemisphere. And this sort of maps on very closely to the levels of alcohol-related harm. So the darker the red, the more there is alcohol-related deaths. So Northern Europe, Russia in particular, have high levels of alcohol-related harm. And these are deaths from alcohol-related cirrhosis, which again is sort of around the same areas in the globe. And it causes 3 million deaths each year. That's 5%. 1 in 20 of every single death that occurs on the earth is due to alcohol. And in younger people, that is actually 1 in 8 cases. More than 1 in 8 people who are younger adults die through alcohol use. And this is the worrying trajectory in the UK. So you can see this is a graph that shows the number of cases, so the deaths from alcohol-related liver disease over the last few decades compared to other diseases, other conditions. So you can see that in people who've got other chronic conditions like heart disease or diabetes or even some cancers, their chances of dying have been getting better. Fewer people have been dying from those conditions over the last 20, 30 years, whereas for alcohol-related liver disease, the trajectory is upwards. So it's something we need to address and think about. How do we tackle that? The final bit of epidemiology, or the data I want to show you, is that alcohol-related liver disease is a disease of disparities, of inequality. So this is a graph that shows the average age of death from alcohol-related liver disease, and it is about 58 years is the average age, but in the more deprived groups of people, the people with alcohol-related liver disease die on average 6 years earlier than those from more privileged backgrounds. So socioeconomic factors are a big driving force, but also there are other inequalities to do with gender, other cofactors like obesity, food insecurity, nutrition, and these are the things that really drive liver disease in the people that are most in need of help from us. And one other final point, this is a very liver-centric slide, but what it demonstrates is the point that compared to other liver diseases, we're pretty good at picking up some cases like things like autoimmune disease, which is pretty rare, viral hepatitis, which is a bit more common, but we're terrible at picking up people with alcohol-related liver disease, and they don't come to us until they are in a heap, like I showed with Joe, and by then it's very hard to change their trajectory. So what I want to show you is that alcohol use is highly prevalent. I don't need to tell you that, you know that. It is a disease of inequalities, and it presents very late. So these are the challenges that we need to deal with as a society. So the final part of the talk is about what can we actually do about stigma. We know, I've shown you that this is the underlying factor that's driving alcohol use and liver disease. So what can we actually do? And it's not all hopeless. There are lots of evidence-based anti-stigma interventions that we can apply. And there's been research in lots of different fields, and this is not my area of expertise, so I'm showing you data from other people, but there are studies that have looked at comparing different forms of education, advocacy, social contact, and involvement of peers. And of course, public health measures such as introducing the minimum unit pricing for alcohol, which has been a very successful measure in Scotland, but that is another way of dealing with stigma, which is the structural side of stigma. The ones I've highlighted in red are the ones that really have some strong evidence base for benefit and effectiveness. Education, social contact, which means actual contact with people with lived experience, and then the use of people with lived experience actually involved in supporting people that need treatment or in recovery. So this is some data that was taken from a large study which looked at many different studies and amalgamated it into one, so it's called a meta-analysis. And this showed that from over 70 studies that the use of education was effective at reducing stigma, but when you add the person with the lived experience, the peer support or the social contact, it really had a much greater impact on reducing stigma. This is not directly from the addiction field, this is from mental health and other conditions as well, but it shows that when we have the right kind of intervention, it can be very effective. So this is the key way of how we can actually tackle stigma, involving people with lived experience, PWLE on this slide, and involve them in every aspect of introducing an anti-stigma intervention. So all the way from participating in the design of the intervention, the delivery of that intervention, and then the evaluation of it. It needs to come with people that understand the situation, people with lived experience. And the reason it works is because it promotes self-efficacy. It helps people gain motivation for change, gives them better self-esteem, and it has the benefit of reducing all the social stereotypes and discrimination that people feel. And importantly, the studies have shown that it reduces that feeling of dehumanization, which is such a terrible aspect of stigma and addiction. So I always show this slide and a couple of other, the following slide to my colleagues, healthcare professionals. So I'm trying to raise the awareness in my colleagues that we can all be stigmatizing, we can all be discriminatory, and the first step is to reflect and recognize that in ourselves. And how do we do that? We tackle those issues I showed you earlier in the slide around knowledge, attitudes, and behaviours. And this doesn't just apply to healthcare professionals, this applies to everyone, the general public. So I always ask people to think about themselves, what's their knowledge around this condition? Do they understand why people with alcohol-related liver disease end up with that condition? Do they understand that it's not always related to a personal choice, it's an addiction? Do they understand what addiction means? And then think about the way their attitudes are. They may not be able to change their attitudes, but to have an awareness of them is very important. And then the final thing is to think about their behaviour. So thinking, how are they interacting with people with alcohol-related liver disease, aware of making sure that they are treating everyone equally and fairly, and just trying to reflect on their behaviour is an important aspect. And one easy win, which I think I've implemented, at least in Plymouth where I work, is the use of the right language. And that's the first step to really help people reduce the barriers or stigma against groups of people. And there is some recommendations from some of our international societies that have recommended we change the use of the word alcoholic. And so all these different terms and conditions that we used to use, so alcoholic liver disease, we don't call it that anymore. It's alcohol-related liver disease, alcohol-related rather than a disease. So it's person first language, person with alcohol-related liver disease, a person with alcohol use disorder. So that's a very easy change to make and has quite a big impact when we deal with patients with these conditions. So I think I've shown you a few tools that we can use to try and tackle stigma. There are effective interventions, but we need to test them and use them in the right context for alcohol, and that the use of people with lived experience is the best strategy to try and have an effective intervention. So finally, I want to tell you about the Arms Hub project, which is a project I'm leading, funded by the National Institute for Health and Care Research, which is aiming to tackle stigma in alcohol use disorder and alcohol-related liver disease. So our objectives were really to engage with lots of different people from different backgrounds who have lived experience of alcohol use disorder, and then understand what are the main issues around stigma that we need to address, and how do we actually do that? How can we create an intervention, something that we can do to help tackle some of these questions? So we held lots of different meetings with experts, as well as around 30 to 40 people with lived experience from different aspects. Some of them had received liver transplant, some of them were in the active phases of alcohol use, and they all had very different perspectives. So we gathered all of that information, we broke it down into understanding what themes were common in all those discussions that took place, and we came up with an analysis of those discussions and came up with these main themes around stigma, which very much align with what I've told you already. So first of all, education and awareness. So the public awareness is poor around the effects of alcohol, the harms of alcohol. The education of healthcare professionals was thought to be lacking around alcohol and addiction. And then accessibility to the right services, that the structural stigma around the way different services are commissioned and function was highlighted as a major issue. And then the other two aspects around language, which I talked to you about already, and the culture, how alcohol is portrayed in the media, how the public perceive the use of alcohol, how it's sort of all pervasive. That's a major issue that drives a lot of stigma for this group of people. So this is what we came up with this big group of people and experts by experience. Came up with these three questions that we can try and tackle through research. Can we educate healthcare professionals? The first one is, can we educate the general public? And there was a real sort of keen feeling that we should be educating school-age children, not just adults, but we should start young. So, can we develop some sort of educational tool that will be effective to tell young people, the harms of alcohol? Can we then also do the same for healthcare professionals? Can we educate them and try and reduce the stigma that healthcare professionals have to this group? And then finally, how can we actually integrate those services that are so siloed? And can we integrate mental health care with liver services and addiction services? And so we are taking forward some of these questions into research projects that will then hopefully produce some answers and some methods of dealing with it. So there are some some ongoing projects that are tackling the healthcare education issues. How do we implement that in primary care? And then also around how do we develop an integrated system of care that will help people access the right kind of support that they need. So this is the final conclusion slide. I think I've shown you that alcohol-related liver disease is a growing problem. It's a global issue. I've shown you that stigma is really the underlying force that drives a lot of alcohol use and alcohol-related harms. And I've shown you that there are some effective strategies we can use to tackle stigma, and there are some interventions, including using people with lived experience to drive change and reduce stigma. So that's a slide to thank my collaborators, my team in the Southwest Liver Unit, and the members of the Arms Hub project and the funders of the research. So thank you very much for your attention.
Yeah, thank you very much, Aswin. It's so refreshing to hear a senior clinician talking about stigma. I've worked with some great clinicians who are really good at working with the presenting clinical problems sitting on the chair in front of them, but they don't think so much about the social context that that person lives in and all the other things that are going on. That breakdown of stigma into different types as well was fascinating. Institutional stigma. You know, Anne-Marie's already mentioned about not being able to get sustainable funding for the recovery walk each year. It's not a fashionable cause, is it, addiction recovery? And the stuff about self-stigma, how people internalise the voices that they're hearing day in, day out. But yeah, that link that you made between stigma and clinical outcomes, people being 6 times less likely to ask for help if they're feeling stigmatised, you know, that's made it very, very real and a really good start to the day. You've set the tone. Thank you. So our second professor for the day, Sarah Page. Obviously, I've known Sarah because she works at Staffordshire University, which is next door to Telford. And Sarah's been involved with a number of research projects over the year around addiction and recovery. I didn't actually know about this one until, again, somebody sent me the link when they found out what the theme of the conference was. The focus of this piece of research that Sarah's going to talk about is specifically about how stigma acts as a barrier for women to access alcohol and drugs treatment. So over to you, Sarah.
Trying to navigate both the mic and the laptop. So, I'm standing to share this research project. However, there was lots of people that worked on this project with me, which are named on the slide. So big thanks to them for the work that they did in relation to that. As mentioned, the research project was across the West Midlands, and our funding came from the West Midlands Police Crime Commissioner's Office in partnership with the JABS Foundation. And the funding for this research happened just after the National Drugs Policy was launched, and there was real concerns that women weren't really mentioned in that policy. When women did get mentioned, it was in relation to women who were pregnant and what should we do about them, rather than looking at gender-specific needs. So we were asked to find out about what women's gender-specific needs were and what some of the solutions were associated to that. And ourselves and the Centre for Justice Innovation, which are a third sector partner, were tasked with leading this research. Ourselves at Staffordshire University led the research with women who were accessing services, and the Centre for Justice Innovation led on the side of accessing professionals and their professional viewpoint around it. And we partnered with an organisation called Expert Citizens, CIC, which are an independent group of lived experience experts. And we also had lived experience expertise from our university population who were involved in co-designing the research from inception. So I'm going to do a disclaimer. I am going to be talking about women's issues. There are some sensitive topics that I'm going to cover in terms of race, hate, violence, rape, domestic abuse, and that may well be triggering for people in the room. And if at any point you need to stretch your legs and go for a little bit of fresh air, you're more than welcome to. I'm also really mindful that from the stance point of feminist research, which is saying that kind of male oppression in society has a major impact on women, men in the room might feel a little bit squirmish. So I want to caveat with the fact that you are still my friends. And you can look at the person next to you and say, when she's saying that really mean stuff, she's not talking about me, I'm lovely, okay? So I just wanted to clarify that because it could also feel uncomfortable for people. So that's my first disclaimer around it. So also, men, if at any point you need to leave the room, you're more than welcome to. So in terms of the methodology, I've just mentioned to you that we had lived experience experts right from the beginning, co-designing the methodology, our approach to research. And we opted for conversational research. I'm quite a chatty person and all the people on the research team are quite chatty, so we wanted to find out by talking to people about their experiences. And we ended up speaking to 28 women with lived experience across the West Midlands of accessing community treatment services. And within those contexts, we had 5 professionals that attended. So we'd not typically have one professional per group that we went out to meet with. There as support during the session if a woman needed additional support there and then, or immediately afterwards. All of the women that took part in the research were remunerated with gift vouchers and refreshments, and we also remunerated the organisations whose premises we used for data collection and for the support that they gave the women during and after the session. Further to that, 9 professionals attended an online World Cafe session. If you've not come across World Cafe as a research method before, it's multiple focus groups happening at the same time, and then we're super nosy and we move people around so that they can hear what other people are saying too. Usually if you do it in person, it involves refreshments too, hence the cafe side of things. Sadly, online, it's bring your own. And then we also had interviews with 17 professionals via the Centre for Justice Innovation. So the first bit of findings that I'm going to launch into is that women talked about how the language of addiction itself is stigmatising, particularly if you're walking into a service that says addiction centre. Women much preferred it if there was a discrete venue that you could enter into that might be multifunctional and therefore you may not be there for an addiction purpose. It's quite common sense really. My favourite venue that we attended was a treatment service that was in a shopping mall and there was a very discreet entrance, and so anyone walking into the shopping mall, they're there for shopping purposes rather than necessarily going for treatment. So just a little bit of thought to the kind of language we use above our service buildings would be fantastic. Particularly when we think about religion and cultural beliefs and practices and how addiction is quite taboo anyway and frowned upon, and the extra stigma that comes with that. That may well be adding and contributing to barriers for people to access treatment. We also found in the course of our research that women talked about how in gypsy and traveller communities using drugs is a taboo and it's a private matter. And in that particular community, a woman would not speak to a man about any private matters. And so again, just thinking about those gender sensitivities about who the support worker is in those given situations can help. So we have a woman here that said, if I had a geezer for a worker, a drugs worker, there are certain things I wouldn't be able to tell him. When I was offered the opportunity to move over to a women's only service, this felt best. No matter what you say, they, referring to the women's service workers, would go to the end of the world for you. They give you more like family support. And so there was very much that sense of additional support that came from a woman support worker to a woman service user in that. So as a point of reflection, I'd like people to just simply think about whether or not the signpost to your service is stigmatising. And can someone walk through the doors without shame as a result? And are staff representative of the community they're trying to reach? I want us to think a little bit about exclusion as well. Similarly to my colleague who presented earlier, we also found that professionals in staff can behave in ways that stop people being able to access services. And one of our criminal justice specialists in the research commented, they referring to women, do get aggressive sometimes when they turn up at the hospital and they can get frustrated. The only way that they can get their point across would be to shout. So they're asked to leave. Sometimes security are called and sometimes the police are called. So then they're out in the cold and they're in withdrawal. In context to this would have been a woman maybe going up to the reception hatch and saying, I'm beginning to withdraw, could I have some medicine just to help me get through while I'm waiting? And then getting increasingly agitated as they're told that actually we're not going to provide you with any medication in that situation. So then we have a woman who is forcefully removed from the hospital, and essentially she's displaying trauma response for the withdrawal that she's going through. And then that puts her in a real position of vulnerability because of withdrawal. What does she do? She can't get the treatment that she needs in the hospital, and so what's she going to turn to in that given situation? Women directly said things like, as soon as you say you're drunk, they, the ambulance professionals, said they won't take you if it's alcoholism. So yeah, that's another thing. You've got to sober up before you call the ambulance because they won't take you. And we've had this in multiple research studies now where healthcare professionals actually deny services to people because they're intoxicated on either alcohol or drugs. Another woman commented, when you've been in and out of the hospitals, they know you. They get sick and tired of you, don't they? Commented another. They stand at the bottom with the curtains closed and they're talking about you. Oh, she's an alcoholic. She's been in here. You hear it so many times and then they treat you like that. So again, that language from professionals, the disrespect, curtains are thin. Walls are thin as well. And so the kind of comments to people's face as well as behind their backs are really inappropriate and don't help with building trust. We found that repetitive service contact, whilst intoxicated or withdrawal, seemingly elicited this increased level of stigma from professionals. And some professionals perceived drug users as less than honest. So there was an assumption that if you're a drug or alcohol user, you're a liar. And this is also a barrier to a productive working relationship. I'm going to just add a little bit here. We found it really interesting that some of the women had experiences where professionals had lied about them too. And so there seems to be rather a double standard that happens in the assumptions of who's the person involved in lying. We also found that women constantly repeated, honestly, in the conversations to kind of re-emphasize that they're being truth tellers, and really they shouldn't have to say that. And that's partly because of the stigma that they've experienced of being treated like a liar through services. So again, a point of reflection, how does your service respond to aggressive behaviour? What judgmental views hinder support being authentically offered? Moving on to the police. Women experienced professional violence that was quite disturbing. One woman says, I've been beaten up by police officers plenty of times. They're meant to have some kind of trauma training. I got arrested so many times before I went to prison, and all I needed was someone to care a bit more and actually help me. I had mental health, undiagnosed since I was a child. And they're just tarnishing me, thinking I'm just a criminal, when really I was just a mum that needed help. In this particular quote, the undiagnosed mental health from childhood, the majority of the women that we spoke to had been in looked after care or had been abused as a child and didn't end up in the care system. And so very often the mental health is in relation to abuses that have been experienced in childhood. And essentially this mum was a woman crying out for help, needing support, and instead got beaten up by police officers instead of found out as to why she was there in the first place. Another woman comments, I got arrested and I seen the police doctor. He let me take as many drugs as I wanted to, then said he needed to examine me and sexually assaulted me. I told the police about it and they just let me out. They just got rid of me. I used to think, have I made that up? Did I dream it? Did I get it wrong? Then I started working and mentioned the name of a hospital where they got their first paid job after recovery. They were super excited about that. And there was a doctor there who knew about my addiction. He would say, right, okay, you've got to suck my willy or you've got to sleep with me. If you tell people, you'll lose your job. I was quite horrified by this woman's account. I was quite shocked about it. And so I was thinking, I wonder what the culture in the NHS is towards kind of sexual harassment in the workplace. And there's a number of studies calling for the NHS to do a full investigation because many women in the field as professionals have also experienced abuses in their workplaces. And so the culture that we're putting our most vulnerable in does need a review and does need to have a think about in terms of the behaviour. The doctor at the police custody suite, he did end up in prison. He was raping women and raping child victims that were coming into the police custody suites. The lady found that out as a result of doing a little bit of her own Google searching on that particular doctor, and that was the point. She was like, I didn't imagine it. It did actually happen. He was dodgy. Professionals also asserted that the police had stereotypical views of women, which can be interpreted as sexual stigma, so stigma that's associated to sexual exploitation practices and sexism. So here the professional commented, we still hear statements from the police, if we're trying to support a woman who's involved in sex work to report a rape, we still hear sentences like, oh, well, she was asking for it, or it's part of her job. And the other part of professional violence I want to touch on is that women also felt the violence of having child removal. Very often, women who had children would have the child removed with no form of trauma-informed support from the social worker. And that kind of stigma from that and the violence of having a baby removed either in hospital after giving birth or later on down the road had really detrimental impacts on women. It would lead to women drinking or taking drugs even more so and struggling to access services. And so a little bit more thought about how we support women through that journey is needed, particularly when we consider that those women are a legacy of an inappropriate care system. Still talking about the police. As a result of stigmatising behaviour from professionals, it's no wonder that women felt unable to approach the police for help regarding their own crime victimisation. Pretty much all of the women that we spoke to were either present or past victims of domestic abuse. And none of them felt able to report their victimisation to the police because of the way the police were behaving. A quote from one of the women, so many women in this room say, we don't trust the police. We can't ring the police and we can't ask them for help or anything. Imagine how many women are out there going through what they're going through right now in their homes and they can't call the police because they don't trust the police. It's wrong. And a few of our women also specifically commented that because of police racism, it added to and confounded that barrier in terms of accessing the police as well. So a further point of reflection for us, are professionals in your service behaving in ways that build trust and are trauma-informed? Are there mechanisms for reporting crimes and issues that provide a supportive process? We also found that there was a lot of victim-blaming behaviour. So there was a lack of understanding around interpersonal terrorism. I'm using that term quite intentionally to talk about domestic violence that resulted in victim blaming. So here we have a specialist worker that commented that they had set up a multi-agency team of the police, probation and the council and drug services and street outreach team. And she was really excited about the multi-agency team. It was everything that you would expect for best practice in terms of reducing barriers to accessing different services. However, these were the views that came across from a manager. They were looking after this one girl. She was using crack, she was pregnant, and she was in a DV relationship. And we rang to get her an emergency move. The person at the council, her words were, well, it's her own fault because she keeps going back to him. So no understanding of why a woman might end up going back to an abusive partner. And that happens vice versa for male victims of domestic abuse as well. However, some professionals did show insight and understanding. So, for example, if you're being controlled and manipulated at home and you feel unsafe, are you going to feel safe enough to go into a service? Have you got autonomy in terms of making that decision? So for women who are in abusive context, just to access a service and go through the door is a challenge in itself. Another quote here, so they're in a domestic violence situation. It's that one moment that they just flip and they attack the partner. Then obviously they come through to probation, aggravated assault or whatnot. But actually there's so much more background and so much more trauma that's happened to lead up to that one event. So very often females may end up assaulting their abusive partner and end up picked up by the police and seen as the perpetrator in that given context. We had one woman tell us a story about how she was, her husband was trying to stab her in the family home, and she got out of the house naked because she needed to flee and escape, and she managed to get the knife off him. And so she was screaming as she was going through the streets, and one of the neighbours kindly contacted the police to get some help for her. However, by the time the police arrived, the husband was out, and because she had the knife, it looked like she was the attacker and she was the one that got prosecuted in that given situation. Women did not always even recognise they were in abusive relationships, particularly where the abuse was happening both ways. And being in a women's only service was the space where women were able to actually talk about what was going on, and for people to actually start saying, actually, that's an abusive relationship. Maybe you could get some support from that. There is a piece of research that suggests that there's more likely to be male perpetrators within drug and alcohol using male cohorts. And so there's particular vulnerabilities then for women in those situations. And having done domestic violence research with male perpetrators, I'm really mindful that the majority of those perpetrators have been sexually abused or violently abused in their own households when they were growing up. So, some gender stereotyping that also happens. Professionals noted that females that access services tended to do so as a last resort, more so than men presenting. And a lot of that was due to gender stereotyping. So one drugs worker comments here, I wonder if it's because the role of the female in families and caregivers means that people try to cope. Because of stigma and everything else, it's that why we see people at last possible moment before things get really pear-shaped. So they're presenting in need and somewhere else in crisis, and then they're being directed here or pushed here as well. And so females particularly will try and keep it together in the family home was the trend that we saw from both the females talking to us and the professionals, and are reluctant to access services. And part of that is that fear of social work involvement if they have children, and the fear of child removal. Keeping children, therefore, can be a stimulus to recovery and support recovery. Many women talked about, I'm doing this for the future and that I might be able to access my children again in the future, but it was also a barrier to get support in that concern about the child removal. People felt particularly judged by social workers. That's not a surprise. One woman talks about a devil-possessed social worker here in this quote, and said about right from the start it was obvious that she was setting me up for fail, and this particular social worker she felt was dishonest in the accounts, in the paperwork about her too. Women described that their drug and alcohol intake increased due to child removal, and I found it really interesting that only one female said that she had been referred to a bereavement counsellor to process the loss of her child from that removal service. So very few services actually say, okay, this is how we can support you around that. So what are some of the gender differences with treatment needs? There are some structural issues impacting stigma that Addison also talks about, and our colleague earlier also mentioned these structural issues, and we argue that there's logistical and operational issues that need to be considered too. Males in mixed group sessions minimised women talking about their DV victimisation, and there was also predatory behaviour towards those women, and wider oppression that was impacting them. And so we advocated really strongly for gender-sensitive services and gender-specific services. I found it quite shocking that I went to a women's-only service that was designated specifically for women with babies. And it was a terraced house with no lift, and you had these skinny stairs to get up to the top floor where you could have counselling and you could access some baby clothes for free. And then you had to go back downstairs and then back down a further steps into the basement to actually do your P testing and to have the more clinical interventions that took place. And there was only enough space on the entrance floor for one pram. I was like, what is that? I've got primary age kids, so my baby years are still quite familiar. And I was like, I cannot believe that someone went, oh, this is the perfect friendly space for babies. So some logistical stuff needs thinking through. Summer holidays, what do you do if you do have childcare? So you're able to keep your child, fantastic, and you want to access regular recovery services because that's a lifeline to you. Well, I'm not a big drinker or drug user. However, holidays with kids are stressful. They're stressful for me in a state of strength in that situation. So for someone who's fragile and vulnerable, my goodness, where's the childcare in those situations so people can access support? And there was also the logistical challenges. I've got multiple needs. I'm accessing probation, I'm accessing the drug service, I'm having to go over here to get maybe some domestic violence support, and I'm also trying to access a mental health service that's on the other side of the city. And that's quite a challenge, particularly if you've got a baby, for example. And then we had the stigma from professionals too. Some services thought it was brilliant if they hooked you up with a worker that you've previously had maybe rapport with, but actually women found that really difficult. They were like, well, they know my past when I was using and now I'm not using, and I don't feel like they believe me because they know me as I was. So there's some thought about whether or not the woman wants the same worker. In some situations, a woman may well want the same worker. In other situations, they might not. So let's listen to people. And then we had issues around mental health support needs. Most of the women that we spoke to were waiting at least 18 months before they could have a mental health assessment, if not longer. Only one women's only service was able to get mental health support instantly within 2 months for women, 2 weeks for women, so that they can process the trauma that they've been through. So how might your service better support childcare needs, and what are the wider women's health and wellbeing issues that need addressing? The biggest point is this importance of a non-judgmental relationship, and I'm sure that this works across both males and females from the wider research that I'm involved in. Women talked about the value of having someone with lived experience, talking to you as a way of not experiencing shame and the kind of support that you get in that context. And women also talked about how you don't have to have lived experience to be therapeutic with someone, but if you can be non-judgmental and you can be empathic and have compassion, that really helps. And the importance of creating that safe space where women aren't going to experience predatory behaviour also came out in the conversations and the quotes that you can see there. Women particularly appreciated women's only space when they were talking about their victimisation of rape and domestic abuse, and also when they were talking about other issues. Some of the women were talking about the pains of going through perimenopause and menopause, feeling that myself, and how that women's only space really helped to be able to talk about those issues and how it was affecting their vulnerability to drugs and alcohol. So, from the findings, we really felt that there was a case that co-location of services is really important. This is something that our sector's gone on about for years. We've said we would like a one-stop shop where everything gets fixed in one place, and we're still saying it, sadly. Here we have a fantastic worker that said, so if they've missed a couple of probation appointments, but they're still engaging with me, I would say, right, okay, come into the office because probation is going to see you as well. And services that got CPNs to come to them to then see people and try and push through the mental health support was seen really positively. We need to consider appointment waiting spaces and whether they're safe. We need to think about whether or not there's past or ongoing trauma and make sure that there's support around that. We need to avoid people having to retell their stories to multiple professions. Can we not co-assess and share that data? And we need to make sure that there's follow-up care. We had women talking about how in certain HMPPS assessment tools, it would simply ask the question, are you from looked after care? And then the woman would say yes, and it would be ticked, and that would be it. And there was an assumption that because a woman might be in her 50s, that she's had support already to process the trauma that she's been through. Only one of our women, again, had been offered any trauma support from being in looked after care. Nobody else had had actually trauma-informed support to process how it's felt from being removed from their parents and the abuse that they've suffered. Professionals regularly spoke to us about the importance of one-stop shops and how they would appreciate that, as well as the women. We also have a series of stigma reduction recommendations that were co-designed with our women with lived experience. So when women are working hard to be authentic, they want authenticity back from the workers and they want transparency. Having greater transparency about what's recorded by professionals, an opportunity for service users to correct accounts, or at least have it on record that they disagree with the account, could help to build trust. Really practical things, and under GDPR, I don't see why that should be an issue. Professionals demonstrating the core conditions of empathy, non-judgmental practice and congruence provide the right environment for women to feel safe and disclose issues and process stigma-related harms. Basic person-centred counselling philosophy and skills would be useful for all professionals. And so that's professionals right from drug and treatment services, healthcare professionals, social work, housing, prison and the police. Professionals adopting motivational interviewing practices of rolling with resistance would also support a more trauma-informed approach when women vocalise their frustration at service providers. A mechanism to reduce hierarchical stigma pertaining to substance use and engagement in the criminal justice system was through women coming together and sharing similar lived experiences. They were not alone on their recovery journey. Women-only therapeutic groups can help women in talking about life challenges that they've experienced. Women welcomed lived experience experts working in recovery as support worker roles because they enhanced the empathy that women experience and provided role model and inspiration. I loved one of the services that we visited where women that had previously been through recovery would come back for events and would kind of champion other women and say, you can do this. We all need the encouragement. Social harms to women who use alcohol and or drugs, including stigma-related harms and engagement in the criminal justice system, could be significantly reduced with timely gender-informed and trauma-informed practices for girls and women who are using drugs and alcohol to self-medicate from traumatic experiences. The police adopting a trauma-informed approach to arrest and detection practice would be welcomed. I was really excited. Staffordshire Police have asked us to do a series of trauma-informed videos to train their custody sergeants and are looking at some trauma-informed practice for both men and women that end up in custody that are using drugs and alcohol. So I look forward to seeing how that gets rolled out and what happens with that. My assumption is that it will probably result in less police officers being punched. So I'm sure that they'll be very delighted by the effects of just being a nice human being. Mandatory training with all professionals is really needed around trauma, gender discrimination, harassment, ethical professional practice, being non-judgmental, etc. And how to process customer complaints so that if people do come forward and complain about a staff member, it's taken seriously. Increasing the workforce alongside allowing for reductions in workloads and increased supervision of practice would be helpful for ensuring a trauma-informed approach is viable and misconduct is taken seriously and gets reduced as a result of the supervisory practice. Combined with creating communities of practice with lived experience involvement, we strongly advocate that the lived experience voice needs to be all the way through service design, delivery, and also in evaluation and research. So there are recommendations for practice, and I believe you're going to all get copies of the slides as well in terms of accessing wider reading. Thank you for listening, and I do apologise that I've touched on some really sensitive and raw stuff, but hopefully it also keeps it real. One of my favourite things has been that, again, locally in Stoke-on-Trent, as a result of the findings of this, our commissioners decided to appoint a part-time, sadly, but it was better than nothing, women's worker that started a local women's group, and we were already seeing 50% more women entering treatment as a result of accessing that group. And we know that across the West Midlands, all of the commissioners took it really seriously. The commissioner who had commissioned the building that I described for the pram instantly was on the phone to the service saying, "What are we doing there? We need to move." I was like, yes, you do. So I'm pleased that we're starting to see seeds of change as a result of the findings, because like all of my colleagues that are presenting on the research, we don't just want it to sit on the shelf as academics. We want it to actually influence policy and practice change to improve health outcomes for people. Thank you.
Well, thank you, Sarah, for that hard-hitting presentation. People like me involved with commissioning or providing drug and alcohol treatment services for, the last 10 years, we've been grappling with why are only 25% of our treatment population female? You know, it doesn't match what's going on in the wider population. I think a lot of the answers were there in your findings. So, for example, where I work in Telford, we recognise that lots of women won't ask for help if they've got children because they're frightened those children will be removed. So we set up a family safeguarding service to work with those families and try and keep the families together. And then we all patted ourselves on the back and thought, what a great job we've done. That will solve the problem. There were so many practical things in your presentation, like thinking about venues, the gender of the workers, are mixed groups, you know, a good thing or a bad thing. And one thing that kept coming through was about the understanding how trauma affects how people react and respond in different situations. So yeah, a lot there I'm going to take away back to my day job on Monday. Thanks. If you are struggling to read what's on the screens, we are going to combine all the presentations and we'll put them on the FAVORUK website next week. A short-term solution is just move nearer to the front as well. So as well as 3 professors, we've got 3 different kinds of experts who are going to talk to us today as well. People whose credentials are their own lived experience. And the first one who's going to talk to us is Claudia. Is Claudia here? Yeah. Thank you.
Oh, I thought I wasn't going to reach the microphone at one point. Hi, my name's Claudia, and when the opportunity to speak here today was mentioned to me, and the subject matter about stigma, I suddenly realised I need to ask myself if the stigma that I've been feeling through parts of my journey previously was mostly my own. And what did that mean, you know? So I'll take you back briefly and give you just a small bit of background about myself so you can know where I'm coming from and understand why I'm speaking about this. So after following what seems like a pretty typical progression of different substances, I finally found what I thought was the answer: heroin and crack. Also alongside opiates, other opiates, dexedrine, benzos, methadone, and various medication concoctions that my interest and knowledge of pharmacology came in very useful. Over the years, I had many treatment episodes and perceived quite a lot of stigma towards me from different professionals, which kind of just fueled that negative narrative I had already internalized inside. And I think one of the most significant experiences that I felt really impacted me and changed the way I behaved, you know, someone mentioned about trauma and how that changes our behavior, and I really see that in this, was when I had my son. So I was on methadone during my pregnancy, and also had a lot of social services involvement, and a lot of very regular urine tests where I had to give the sample with a nurse about that far away from me, which obviously on reflection now I understand that. At the time I didn't. At the time it kind of very much fed into, you know, you're not trusted, you're not a proper person, and sort of that kind of narrative. So I felt then that it was a kind of start of me starting to live up to the stigma that was sort of in my head and what I was experiencing. So almost becoming like a sort of self-fulfilling prophecy. And it made me kind of very scared, very defensive, very dishonest because of the fear and full of self-hate. So of course it impacted my behaviour to other people around me, especially professionals, which did not do me any favours. I felt like I didn't deserve to have a child. I was too afraid to be honest with services. It made the whole situation a lot more difficult. So instead of enjoying a pregnancy, it wasn't about that. It was about running and hiding and trying to say and do the right thing and being one step ahead, you know. And it wasn't beneficial. I felt I didn't deserve to have my child. I was too afraid to be honest. I felt in my mind I was protecting myself and my child. Obviously, on reflection, that's not how I see it now, but that's how I felt. I felt I was constantly being tested to be caught out by professionals. So my pregnancy was always full of anxiety and fear. And it was just not knowing what the best way to go forward was. So it was feeling very isolated and very kind of like, if I say this to this person, what does that mean? And it was all that. And it was really, really difficult, I'll say. Anyway, my son arrived 6 weeks premature. And of course, the first thing I was like, oh, it's all my fault. It's because of my drug use. And to add insult to injury, when that happened, there was questions around my breastfeeding because at the time I had hepatitis C, and they were concerned about the risk of transmission. But that just kind of further kind of dented my kind of very fragile, if I even had some self-esteem, low self-esteem, and just kind of reiterated to me that, I was nothing. I was worth nothing, and I shouldn't be here, and I'm not a proper person, So alongside that, I was being observed with all my interactions with my son. He was put into special care. And so, bathing him, holding him, feeding him, and I was there every single day, all day pretty much, doing all the feeds and everything. And they were sitting there writing their notes on everything. And at the same time, I had to keep it a secret from my family. They didn't know I was on methadone. They didn't know that my baby was, had been born with opiates. So it was a real, when I look back now, I think, God, it was like I was running from one thing to the other, trying to remember this, trying not to say that, and it shouldn't have been about that. It should have been about me, and it should have mostly been about my child, and how I could sort of move through that, and there wasn't that support. So he was being observed, and they were making their notes, and I didn't see that as a protective factor. It was just more confirmation about not being a good mother, not being worthwhile, and really negative, unhelpful narrative in my head. And it just fueled the anxiety. It fueled I'm not good enough. It fueled second-guessing my role as his mother. It started to silence my voice as a parent, which would stay with me for many years. Added to this, I was openly given my methadone on the ward in a massive 10 ml syringe, as opposed to a cup. So, because obviously it's bright green, people were kind of like, okay, what's going on there? So again, I felt paranoid, and I felt very much like I didn't deserve, or I wasn't able to have privacy or confidentiality like the other people, and that because of who I was, that was why. The attitude was, here you go, and I know most of you probably know, today, even if you go on supervised consumption to a chemist, they're meant to give it to you in a respectful, kind of out-of-the-way way, if they haven't got a separate room. That wasn't part of it. The curtains didn't get drawn, nothing. It was the big 10 ml syringe. So that did not help. There were occasions when the nurses were openly talking about me and my son, about social services, about my hepatitis. My notes were left on top of the desk where people used to go up to talk to the nurse, so they were openly able to see them. But I think the worst was hearing them talk about me, because I knew everyone else could hear it too. Again, it kind of separating me, that, and just, again, just telling me, you're not good enough. What are you doing? This is your fault, So, and at the time I didn't feel to challenge it. I couldn't challenge it because I just felt really defective as a person, very powerless, and just that I shouldn't be a mother. What was I doing? This isn't, I'm in the wrong place. I shouldn't be here. So when it was explained to me that my son then would need a morphine detox, it really upset me. I cried, and I felt really bad. And the staff's attitude was one of surprise, which I interpreted as I was treated like, well, what do you expect? It's your fault, so you don't have the right to feel like that, So, and I felt then that a part of me did shut down that day, definitely. So, just adding to the self-hatred, the reinforced distrust of professionals, and affecting my behaviour and my interactions with other people, which were not beneficial to either me or my son. So bringing it slightly more present, well, not that present, but so after 30 years of using alcohol and substances and multiple failed attempts at recovery, I finally ran out of energy and everything else, so I just stopped fighting. This, I later learned, would be a massive pinnacle in my life. So here I was, 40-something, child in an adult's body, an IV drug user with a dependency on both alcohol and drugs, prison and a list of failed rehab and detox attempts behind me, a mental health diagnosis, Hep C, a criminal record, and 2 children whom I was estranged from. So basically every stigma going and some. I'd been in the system for what seemed like forever. I knew a lot, I could articulate well and talk a really good game, but could never connect what I learned with actually doing it. I totally sort of misunderstood the concept of putting the work in, you know, actually having to get off my bum and do something, and not just talking about it, and started to feel that maybe I wasn't bad enough for the help. Who knew? So I experienced mixed reactions and labels from my interactions with various professionals, from things like serial relapser, lost cause, too old to change or be put forward for rehab, knows what to do but doesn't want to do it, and the classic safer and better on methadone. I was filled with shame, self-hatred, and no self-esteem. I'd lost hope and started to believe all the stigma that was attached to me and that was blocking me being honest and accessing treatment and help that I needed. And I now feared treatment and professionals. It was not that they and it was not a safe option for me. More a feeling I had to be one step ahead of the system. I didn't trust it. I found it easier just to accept the stigma I believed about myself than continue to try and fail repeatedly. However, for some reason, I couldn't settle or accept my life like this. I felt there had to be something different, but I didn't know how to get it or what it looked like. I wasted so many years locked in the stigma that was in my head, which prevented me from moving forward. So here I was 44. I felt there was no one to help me, that my age was a major barrier to the treatment I felt I needed, particularly detox and rehab. A methadone script with an increasing dose was the only treatment support I thought I could get, reinforcing that I was beyond or not worthy of any help and that this was my life. I wanted to stop using, so feeling I had no other options, I had to try and do it myself. In my mind, this was the only way not to get trapped into the system. I trusted no one, so I decided not to tell anyone what I was doing, especially the professionals giving me my script. The fear they would just keep increasing the dose or block me moving forward was too much of a risk. My first step was to stop using the illicit substances on top of my script, something I'd never ever managed before in the community. So I continued to pick up my methadone, but started to reduce myself the way I knew worked for me. This took me approximately 6 months, and during this time I was assigned a new key worker. To my absolute horror, I'd been in treatment with this person years before. And the shame descended down on me like a dark cloud, and I could virtually not even say hello to him. I reluctantly started to work with him and gradually took a risk by telling him what I was trying to do. To my absolute amazement, he encouraged me with hope and positivity. He was the first person who did not buy into my self-styled stigma or facilitate my self-pity. He encouraged me to look at the positives of what I was doing, even when I couldn't or wouldn't see it for myself. He helped me to start to see through the stigma, challenge it, and see that I was more than that and have some hope. His attitude and confidence in my ability had a massive impact on me, and I use this with clients I work with today. And I do want to add, which I hadn't written in here, which I remembered, is that I'd also refused to work with male key workers for a very, very long time. Nothing against any men in the room, but just that was just something that I did. So on top of someone that I'd known from treatment, and he was a man, it was kind of like a bit of a double whammy, you know. However, he taught me that actually I could be safe in that environment. So that, you know, that was huge. His attitude and confidence and the impact that it gave me, it has had such an impact that now when I work with my own clients, I am very much like that because I saw and I felt how the difference. Instead of, oh yeah, I've used it, oh yes, I know, it's terrible, isn't it? He'd go, okay, let's try again tomorrow. I was like, hang on a minute, you're meant to be feeling sorry for me here. You're meant to be offering me more methadone. This isn't that. I'm not used to this. And you know, and I come from a place of I never know who and when someone will make a change. I think every time they engage, it's an opportunity, a window to diminish the stigma that they carry and give them hope that it could be their time to make a change, whatever that looks like, just like he had done for me. So today, I stand here as a 54-year-old, working mother of two. My two children both live with me and continue to amaze me. Get a bit emotional. Excuse me. That wasn't meant to happen. Excuse me. The stigma that I carried for so long does not define me. I believe I'm more than that, although there will always be... So embarrassing, I'm so sorry. I'm just like, ugh. Makeup's going, everything's going. Okay, now I can't read the thing. Hang on, where was I? The stigma, yes. There will always be elements of stigma attached to me, but it doesn't influence who I am or stop me from doing what I do. And in some ways has been a big part in redefining and realising who I really am. It has given me another chance to learn without fear, live without fear, use my experience, knowledge and learning positively to support parts of other people's journeys. It has also allowed me the opportunity to work with others like me, doing a job that I'm passionate about, that is never boring. And I can use my negative experiences for the positive whilst continuing to learn. Today, I'm not mine or your stigma. Thank you for listening.
Thank you, Claudia, for sharing your experience, strength and hope so powerfully. Yeah, what I got from your share was about how the way people treat us leads to that self-stigma and self-sabotage. But then thankfully you met the right person at the right time and that changed everything. Thank you. I'm a big believer that one of the things that can help us overcome that self-stigma, self-sabotage is getting back into the world of work, whether that is voluntary work or paid work, it doesn't matter. It's that sense of suddenly I'm useful again, you know, I'm doing something useful. And that's powerful, and that's partly about self-care and self-respect in early recovery. It doesn't help because of the amount of stigma of people with addictions. Not all employers, you know, can see through that stuff. So our next speaker, Naetha, she's the founder and the director of the Recovery Coaching Academy, and she's been working a lot with employers and with workplaces to try and make them more recovery friendly. And she's going to make the point that actually it's good for business to employ people like us. So over to you, Naetha.
Good morning. Somebody knows me well. They handed me a tissue before I walked up here, so I'm not sure what that means. My name's Naetha Uren, and I founded the Recovery Coach Academy about 4 years ago. We train recovery coach professionals, but we do so much more. We work in a partnership with CCAR, which is the Connecticut Community for Addiction and Recovery in the US. They are a global leader in recovery communities and recovery coach training. They've trained 110,000 people in the curriculum that we train. And I am so grateful that we have trained 1,500 people internationally in that curriculum. And that was not my intention. I'm British. I wanted to do this work in the UK. I wanted to help my local county, my community, my country, and it just was really, really hard. I started Recovery Coach Academy because I wanted to make a recovery coaching community available like we had to help my family and my daughter when we were navigating her addiction and family recovery. And that recovery community that we had access to had professional recovery coaches, paid for, volunteer, private. It had domestic violence support. It had financial support. They even helped us find a child food therapist because that is what we needed in our recovery journey. We went and looked to work with people in England, and the doors just didn't open. But that has been a blessing in disguise because we are making an international impact now. The desire to do this work led us to CCAR, and they have just supported us beyond anything we could imagine. Many of you know William White, and he is an emeritus senior researcher, and at a dinner for the founder of CCAR, he said, there has been a North Star, and that North Star in this recovery advocacy movement has been CCAR. And I am so grateful because the integrity, the relationship building, the professional, the engagement with every employee and that leadership team that has believed in me and supported me, and now we call them our friends, just drives forward. And I'm so excited because the future is looking bright for CCAR UK. The journey hasn't been easy. We've made lots of mistakes. We've had lots of successes. I don't know about y'all, but grassroots organizations starting it, social entrepreneurship in this field is full of ups and downs. And the best way I can describe it is it came in waves for me, and those weren't waves at first, they were tsunamis of self-doubt, lack of support, imposter syndrome, fear. And somebody said to me once, in the Hebrew language, fear means different things. And fear is actually that feeling of stepping into a space that is your calling. Go with it. And that is what this has been for me. Recovery coaching is a calling. Doing this work is a calling. In recovery coaching, we use the word help a lot. And that word, for me, means a humble effort to learn or lend power. And so we were really fortunate to have people that helped us do that. And I knew we were doing the right thing because that very first training, somebody in that course said to me, this is not a course, it is a community. And we have created and continue to create a community that supports hundreds of people. It's not the local community we wanted to build, it's an international community, and it is thriving. So today I want to share some of my lived experience with you. And my lived experience includes my substance use. It also includes everything else, because it is all my lived experience. So I want to talk to you today about why recovery-friendly workplaces are good for business, why real recovery relationships are good for business, and why recovery coaching is good for business. So my lived experience is long. I qualified as a licensed chemical dependency counselor in Texas over a quarter of a century ago. I worked in for-profit treatment providers, non-profit treatment providers. I volunteered for the AIDS Foundation at a time when advocacy for that movement, I learned so much that we apply to the recovery field today. I was part of the first treatment team and the first civilian employee that set up an alternative to incarceration therapeutic community. I have an extensive background in hospitality, and that included customer service training, management training, and leadership training. I trained and worked as a professional coach. I used my skills in all those jobs every day as a coach and a counselor. I am also the glue to 4 generations, ages 82 to 11, that live in the same house. It is flipping controlled chaos, but it is full of love. I've supported my daughter through more than her first 5 years of recovery living in our house. I am so much more than a period of problematic substance use. I have 25 years experience building, maintaining, sustaining, and helping other people build their recovery capital in paid roles and volunteer roles. But this is my calling. So let me tell you why recovery-friendly workplaces is really important to me. We engage with allies in the workplace who can support individuals, families, and organizations to make a positive impact. So just humor me for 1 second. Would everybody stand up? Just 30 seconds, just humor me. If you have been directly or indirectly impacted by someone's alcohol, substance use, addiction, gambling, take a seat. I told you it was only short. Right, I spoke at an employee well-being conference a month and a half ago. It was not an addiction conference, it was not a recovery conference, and I had the same result. Everybody in that room had been impacted by substance abuse or alcohol other than 2 people. And I told them they could have a seat because now they know me, you know? And that's why we need to talk about this in the workplace. Everybody's impacted, pretty much. You know, when I talk about that employee well-being conference, the numbers of conversations that came up as a result of that, just allowing people the space to talk. But first, I want to share with you my lived experience. About 8 years ago, I got a phone call at 2 o'clock in the morning. And when the phone rings in my house at 2 a.m., it is not a good thing. I answered the call. I heard my daughter crying and screaming. I heard my grandson crying. He was 2. I heard her domestic violent boyfriend punching holes in the wall and screaming at her. I was in England, she was in America. I spent the next 2.5 hours on the phone calling my son, anybody I knew who could go and try and save her. Half an hour later, I showed up at work. Tired, brokenhearted. My world was just in chaos and crisis. I went and sought out the mental health first aider. Her exact words weren't this, but I definitely felt like my problems were above her pay grade. She did not know what to do. She told me to go to HR. I didn't go to HR. I was afraid I'd lose my job. I did end up losing my job as a result of my daughter's problematic substance use. I had to step in. I had to go and try to help her find recovery if that's what she wanted. And I had to create a safe space for my grandson so he could be secure, safe, and looked after. But you see, I'm not alone. There are people in this country, in this room, and around the world who are going through exactly what I went through right now somewhere. And we need to be able to have these conversations in the workplace because it's not always the people that are directly impacted with substance use. It's the family, the friends, the loved ones that show up every day and try to do their job. And in the background, they're navigating resources, trying to find support, and they're trying to love someone who's suffering with a health condition. I had a manager reach out to me, and he said, I don't know if you can help me. I've got an employee who's coming back to work. They've been to rehab, and I want to welcome him back. I am scared shitless. What can I say? I don't know how to talk about recovery. Can I ask him about it? I'm walking on eggshells. He said, can you help me? Yes, me, recovery coach Naetha, I can try and help you. We had a lot of conversations. We talked about what addiction was, what recovery was. We talked about how to have a conversation. We talked about the resources that were available. We talked about how they handled other conditions and health conditions in the workplace. As a result of that, he welcomed that employee back to work. They had some conversations. They created an accountability buddy within the work that person could check in with. They offered him access to a recovery coach if he needed it, and they had a really good outcome. You know, when I gave that example at that employee well-being conference, I must have had about 8 or 9 people going, that's me. I want to have this conversation. I'm walking on eggshells. I know I can help somebody. I want to be their ally. How do I do this? And that is why we need recovery-friendly workplaces. But the calls keep coming in my world. You know, I was speaking to somebody last night and they said, you're doing case management and advocacy. And I went, what? I'm just answering a call for help when somebody reaches out. So a few months ago, a general manager, senior manager of a hospital healthcare organization called me. They had a sibling that was suffering with addiction. They didn't know what to do. They were angry. They were frustrated. You know, I said to them, let's meet. We met the next day. We shared a meal. We had a coffee. We spent 3 hours together. I gave her information about resources available to the family while they navigated this time. I gave her paid, sliding scale, and free resources because I don't know what their situation or circumstance is. They deserve all the options. We just had a really good conversation, and we stay in contact, and we keep finding the right resources, and she is helping navigate this. But that is a senior leader in a hospital who didn't know where to get help. And I guarantee you she's not the only one in that organization that needs this kind of help. So that person reached out to me on Facebook Messenger at 6:45 at night. You know, recovery coaches meet people where they are, when they are. And that doesn't mean I am unethical or unprofessional or I have no boundaries. It just means that if I'm available, it did not take 2 minutes to say, hey, I hear you, can we chat tomorrow morning? You know, these people and the reasons that they come to me are the reasons that we need to support recovery-friendly workplaces. We talk about menopause, suicide, mental health. Some places talk about addiction, but we don't really talk about recovery in the workplace. As somebody else said, it seems to be a taboo, and we need to overcome it. And I want to help people because I'm passionate about that. I know how it felt as a mom showing up to work in a senior leadership role and not having any support. We all know that recovery is individual for individuals, for families, for anybody. We all have many different pathways. Establishing a recovery-friendly workplace has to be just as individual. Because a hospital, a hotel, a bar, a restaurant, a ferry driver, a train driver, they all have different needs in their workplace. And I know this because I have had conversations with all of those kind of people. You see, often we're looking for an elusive framework that fits all, and it does not exist. Nothing is going to fit everybody. So we've created a space where we can really co-produce and work with employers to help them start to establish a recovery-friendly workplace. And then we have a real relationship and we continue that journey because establishing a recovery-friendly workplace will evolve. It is not what it starts out to be. My hopes and my dreams for the future are that every workplace well-being team has access to a recovery coach professional, and that the employee wellness schemes work in partnership with recovery community organizations like mine to help provide an absolute buffet of every recovery support service that is available. And I say the word buffet because I mean it. How many of you been to a buffet? Yeah? Do you arrive there and they say, sorry, you can only have the carrot cake and the broccoli today? Everything is available. In as much or as little as you want, you can go back, you can try new things, you can have it all. And that is why we, as recovery coaches, provide a buffet of recovery support services. You know, we don't know everyone's circumstance and situation when they arrive to speak to us. And a perfect example of that is, I had a mom call me. Her adult child had been admitted to the hospital with an alcohol-related issue. She was given referrals to the local community drug and alcohol service, stop drinking. You know, she said, I was treated like I had not a penny to my name and that we were terribly, in poverty, no service. I would pay today to get my child to treatment and help. Why aren't those services made available? So I think it's important. We're inclusive. For-profit, non-profit, clinical, trials, research. We all need to be on that buffet, You've heard me mention coffee and sharing a meal a few times. And this leads me to why real recovery relationships are good for business. Whether it be fate or higher power, whatever you believe in, I believe it plays a part in my life. A perfect example of this was when I faced a really challenging time. As we were introducing recovery coaching in the UK, I don't want to focus on the disrespect, I want to focus on the respect. Because William White says language has power. It can either empower us or disempower us. And it applies to every situation. So I will never forget, by fate, I ended up on a Zoom call with 2 global recovery leaders from the US. I call it a heart meeting. They wanted to know what I was trying to do, why I was trying to do it, what my intentions were, what my vision was, how did I plan on paying for it, could I pay myself, all those questions. But at the end of it, you might recognize this quote, if you know the movie Field of Dreams, they say, if you build it, they will come. Well, they didn't just say that. They said, if you build it, they will come and we will help you. They made a humble effort to lend their power to help. And that is so important in the work we do. That relationship has grown beyond any expectation I could have ever had. They are my coach, my mentor, my business partner, and my friends. 4 years on, we are still growing strong. So when I received a call and was invited to go and help implement and train this recovery coaching curriculum in Qatar, I called them. I said, will you work with me in partnership? They said yes. That was respect. So after years of meeting on Zoom, we never thought that our first meeting in person would be in Qatar, but that's where we ended up. We have worked to create a culturally competent, fit-for-purpose training. We did it as a team. We translated it, we interpreted it, it is heart-centered. We have now trained over 500 people in Qatar. That organization created brand new job descriptions to employ people. They didn't take a support worker and just put recovery coach on the top, like we have seen. They actually really looked at the heart, the values, the art, the science, and have created paid roles that the people who achieve a recovery coach professional designation can apply for and get paid for. We have created a real recovery relationship, and that is respect. That work was presented to 133 countries at the International Society of Substance Use Prevention conference in Greece. We are truly making an international impact. But you see, I didn't dream of that. My dream still to this day is I want to do that work here. I don't care if it is in English, Arabic, or Spanish. You can have your choice. We do it all, But I want to do that in this country with people like you who are willing to open the door. Because sometimes we knocked on hundreds of doors and said, please work with us. And sometimes the door didn't even get shut. It felt like a brick wall went up, So I just ask if any of this can make an impact in your community. Let's work together. Let's create a real recovery relationship on respect, in partnership, and do some good work. I met with another person outside of the country and they said to me, oh, I want to have 5 coffees with you. I was like, shit, I'm in the country for like 3 days. Can we have 2 today, 2 tomorrow, 1 the next day? But what I realized was that person, they wanted to know my heart. They wanted to learn about my family, my life, why I did the work I do. They wanted me to understand them. They wanted to really get to know me and for me to know them. And through those 5 cups of coffee, we created a real recovery relationship so we could do some good work together. Anne-Marie Ward role modeled a real recovery relationship. My daughter saw an ad that the FAVORUK friendships, recovery. Relationships help build disheartening. We floundered a bit. We weren't quite sure what we were doing at times. We needed some guidance and some support. And I reached out to people that I thought shared the same goals and passion that I did. And I heard comments and statements like this: "That is too American, it will never work there." Who are you to do this? You are not a Lero. You are competition to us. You could affect our funding. We love what you do, but you highlight our failings. You see, language can empower or disempower. It can create unity or divide us. I didn't throw in the towel. I persevered. I sought help elsewhere. And this has taught me a lot about resilience, and it's truly showed me and role modeled to me real recovery relationships that are built on mutual respect. I am so grateful for those people that have gone before me. The recovery leaders, the historians, the community leaders, the advocates, the certification and accreditation experts, the recovery and reentry experts, the criminal justice experts. These are the ones who answer my emails, who respond to my Facebook messages, who share a meal with me, who role model servant leadership, and they offer to help me because they acknowledge someone helped them and they're now going to help us. So I dream of a world where we do not see each other as competition, but create real parity, real relationships, and inclusion for all of us who are trying to make a difference. And that brings me to why recovery coaching is good for business. And the best way I can explain this is through my lived experience with recovery coaches. You see, I've had recovery coaches in my life for almost a decade. The first one came in and supported me for the 2 years of support before my daughter found recovery for family recovery coaching. They helped me figure out what my life would look like if my daughter chose recovery or didn't choose recovery. They helped me realize that I had a right to family recovery independent of her choices. When my daughter went to rehab, she was assigned a recovery coach on day one. And that recovery coach was assigned to support her for 2 years. We're now 6.5 years into this journey, and that recovery coach is still in her life. It doesn't look the same as it used to. It's not a regular appointment. It doesn't happen every 2 weeks. It's a text message, a WhatsApp. It just could be speaking once every 6 months. Because we all know, the research says, if people remain in recovery for 5 years or more, they are 75% more likely to stay in recovery. Why aren't we providing support for 5 years? Why aren't we not helping people? They don't need a regular appointment every 2 weeks. They just might need somebody to help. Humble effort to lend or learn power. I also had recovery coaches who helped me when I brought my grandson and my daughter and my mother to live with me. I didn't know how to establish a multi-generational home. There wasn't a book. No, I didn't get the dummy's guide to this. And the early days of my daughter living with me in recovery were not easy. You know, we think when people get in recovery, it all gets better. Sometimes it gets worse before it gets better. It's a new normal. So I had recovery coaches that helped us. And then I was really, really lucky. I had a master recovery coach. And he supported me when I was trying to figure out how to do the work I do today. He helped me navigate dark days when I felt discounted, when I did not feel seen or heard. He helped me realize that by putting other people on pedestals, I just devalued myself. He supported me to be a recovery coach professional. And he said 4 words: I believe in you. There is so much power in language. I also have allies, business recovery coaches. They helped me. They knew what I was trying to do. They helped me navigate what it looked like to set up a new and different and innovative recovery community organization. I was stigmatized at the time. I was told I didn't have the right company house status, you know. I didn't care about that. I just wanted to do the good work. And I'm so grateful. And one of them's here today supporting me. She's my motivator and cheerleader. That's her recovery coach role. So I also want to give you another example, bit of research. I am not really good at explaining research, so forgive me now. So one of the first people that did training with us had an abstract published with the British Medical Journal. And to summarize, people with moderate or severe alcohol diagnosis were given the option to engage with a community drug and alcohol service or a recovery coach. Across all the referrals, 47.9 were currently abstinent 9 months later at the end of the research. 91.3% of those were supported by a recovery coach. 64.6 were still actively engaging with that recovery coach. Of those, 67.7 were abstinent, which compared favorably to rates achieved through the drug and alcohol services in that area. More than half of the people who were abstaining engaged with a recovery coach exclusively. 29.2 of those patients were not even known previously to a drug and alcohol service. So they were finding people accessing services who wouldn't even typically access them. And the engagement and abstinence rate was 85.7% for that group of people. So 62% of the people that engaged with a recovery coach identified as still being in recovery, and only 6% that engaged with the community drug and alcohol service identified as being in recovery. And that's a bit of research. And if you'd like a copy of that, just let me know. But what was the feedback from the actual patients or recoveries that received the service? It was uniformly excellent. Everybody welcomed a personalized approach. Many highlighted the on-demand, you're never alone, a friend rather than an official appointment. You could even call just to have a chat, as well as the perceived informality compared to other services. But what were the conclusions from Diane Blackhouse, Neil Gordon, Lindsay Gorliss of the Hull University Training Hospital? The results show high rates of engagement and abstinence through the peer support offered by recovery coaches. They hope to expand and enable referrals from other sources. Their team has been enriched by the integration of a peer support recovery coach who brought fresh asking to work with recovery coaches. So the recovery coaches who helped achieve these results were all volunteers, and the people who worked for the drug and alcohol service were paid employees. I dream of a world where the recovery coaches are valued and paid. William White warns of the threat to professionalism, the danger we have of over-professionalizing recovery coaching. He says, quote, "We will bleed every piece of juice out of the current recovery coach role that exists." We are already seeing this. Guidelines and standards that exclude people like me. I dream of a world where professional recovery coaches and recovery coaches are valued, where we don't try to over-standardize and over-professionalize this, where we're all included, nothing for us without us. So, as you can see, I continue to engage with many different recovery coaches in my life for different reasons and different seasons, and they all have different experience and different skill sets, and they all have lived experience. It was really funny, I gave that phrase lived experience to somebody in the US, and they said, "What do you mean lived experience?" Everyone has lived experience or they're dead. All of these people have helped me navigate family recovery, navigate doing the work I am passionate about. Some of these recovery coaches were free, and some I really happily paid for their services. I have over 25 years in recovery. I can afford to pay for some things. It's okay. Terence Walton, who's the Executive Director for the National Association of Alcohol and Drug Abuse Counselors, told me that we must create a space for people to make a comfortable living so they can have a nice lifestyle, so they can remain curious, and they can keep continuing learning so they do the great work that we do. Because if they can't have a comfortable lifestyle, they're going to leave this profession. You know, I continue to volunteer. I sit on boards, I participate, I volunteer my time, I offer free and pro bono coaching, but I've got bills to pay. I've got 4 generations at home. That's 2 fridges in my kitchen, not 1, you know? And a lot of people are shamed for doing the work we do using our lived experience. I witnessed a LinkedIn conversation recently where some people who in their bio had, you know, we help empower people and support people, and they shamed this woman who said she was going to charge a fee to speak, and that speech would include some of her lived experience. They put things like, "You should just be on benefits and stay happy with that." They said, "You should be grateful you have an opportunity to speak for free." This was a public conversation on LinkedIn. You know, why do we keep people small? I really struggle at times with the word peer. You know, I am a professional with lived experience. I am a peer, P-I-R, person in recovery. Because the word peer often means volunteer, minimum wage pay. We should be inspiring people to do anything they want to do to live a fulfilled life. Maybe they want to be a plumber, maybe they want to be a CEO, maybe they want to start their own company, maybe they want to volunteer and work. Let's just do it all. Let's not set those limits on people. Because the combination of lived experience, professional development, training, allyship, experience, advocacy is priceless. Like MasterCard, you know? And we need all of us in this field doing all the work we do, because we're all part of the solution. CEOs, academics, even charities, they make a living wage or more. Recovery coaches deserve parity too. So I dream of a world where people can access recovery coaches like I've been able to at every stage of my life in recovery. Initiating it, the stages of change, building it, and thriving in long-term recovery. If we provide this, we reduce the option for reoccurrences. Family recovery, families need support. Recovery coaching can be part of that solution. Recovery coach professionals are change agents. You know, we are really good for business in lots of different ways. Isaac Newton said, "If I have seen further, it is by standing on the shoulders of giants." And I am so grateful for the giants that have let me stand on their shoulders. They have allowed me to learn with them and from them, and that is respect. So, in closing today, I just want to express my gratitude that you listened to all of my lived experience, personal, professional, family, because they are all intertwined. You cannot separate them. But when I found recovery coaching, it was where my heart and my head connected and fireworks went off. And they're still going off today. Every day I love what I do. I love helping people. I love taking those random calls. I just love what I do. So if anything I've said to you today has lit a little spark, and you want to explore recovery-friendly workplaces, recovery coaching, or just share a meal with me, you have to do either the whole meal or the whole coffee and create a real relationship, I would love to do that with you. I know what we do isn't for everyone, but it is for someone, and so it should be on the buffet. But finally, I want to say, please never underestimate the power of language. Find someone who says, I believe in you, to you. Find someone else who needs you to say, I believe in them. And if you can't find someone, that's my contact details. You can call me. I'll tell you I believe in you. Thanks.
Thank you, Naetha. Gosh, you took me back to 10 years ago when I was new in recovery, and at the time I worked for Public Health England, and they hosted this big meeting to set up staff networks, and there was going to be a staff network for people from minority ethnic groups, a staff network for LGBT guys, a staff network for people with disabilities, and I went and quite naively put my hand up and said, can we have a staff network for people in recovery? And the whole room went silent. And people were looking at me and I said, you know, people who are recovering from drug and alcohol problems, and people were either looking up at the ceiling or down at the floor. The organisation that I work for was responsible for formulating and implementing government alcohol and drug policy. But there was this feeling that some things you just keep private, you know, you don't talk about those dirty secrets. I was challenged as well. In my current job, you know, I'm quite well established in my recovery. Am I as passionate now about recovery-friendly workplaces? Probably not. And there probably are people in early recovery that I work with. So that's one of the challenges that I'll be taking back with me. My immediate challenge is, my main job today is to keep us on time. And there's been no speakers this morning that I've been trying to send like hand signs to saying you've got 3 minutes, because they've all been amazing. So our planned coffee break was due to finish 2 minutes ago. I think we've taken in a lot of information. There's a lot to digest and process. So I'm going to suggest that we meet back to start again at 22, and we'll try and pull some time back. So we'll start back at 20 to 12. Thanks.
And also, if you need the loo, the best way to get it is to go outside, walk round to the right-hand side and down the stairs.